everyone, I'm Raquel Borg. I'm doing my presentation on Tourette's disorder, something that has been portrayed quite a bit in movies and pop culture, usually kind of made to be the butt of the joke, but is actually a chronic psychological disorder. So a little bit about the history of Tourette's disorder. It's kind of was named mainly by Gilles de la Tourette in the late 1800s in France. He had been observing multiple people with the same onset age, same symptoms with the vocal tics and the physical tics. Though there are some reports that describe the symptoms of Tourette's disorder that date back to the 1400s, at least. And at that time, they ascribed these symptoms to possession. So there was a story that I had read about a priest that had a lot of obscenities that he would yell, and they thought he was possessed. In between the actual naming of Tourette's disorder by Gilles de la Tourette and in the 1800s and up to the 1960s, there wasn't a whole lot of treatment or management of Tourette's disorder. And we'll talk a little bit about that later and why in the 1960s there actually started to be some treatment. So the diagnostic criteria for Tourette's disorder, there are only 4, but you need to meet all 4 of them to qualify for a diagnosis. So you need to have both motor and vocal tics present at some time during the illness. So they don't necessarily have to run concurrently, but you do have to have had both. If you only have one, you would only qualify for persistent or chronic motor or vocal tic disorder, and the second criteria here for Tourette's disorder is that the tics may increase and decrease in frequency, but have persisted for more than 1 year since the first onset. So there is a time limit. And if someone has all of these symptoms of Tourette's disorder, but has only been experiencing them for less than 1 year, they would only qualify for provisional tic disorder. So it is kind of, there are levels to it. The third criteria is that onset is before age 18. And there is another diagnosis if all of these symptoms have onset after 18 years. And the last criteria is that the disturbance or the tics are not attributable to physiological effects of substance, medication, or other medical condition, which again would be ascribed to another, other specified or unspecified movement disorders. So kind of the hallmarks, the characteristics of Tourette's disorder are the motor tics, the repetitive movements such as facial tics, arm movements, head shaking that are aimless, do not serve a purpose, and are not triggered by previous movement. And then the vocal tics, there is echolalia, which is the repetition of words that someone else hears, and coprolalia, probably the one that you're most familiar with, is involuntary swearing, and that's kind of what you see a lot in movies. And another symptom that is particular to Tourette's disorder is the idea of premonitory urges. And this is a physical sensation that the patient will get before they need to perform a tic. And so they're not completely involuntary, and they do kind of have this like foreshadowing feeling that they're going to have a tic or they're going to need to perform a tic. So the prevalence estimates range from 3 to 8 per 1,000 school-age children. Again, you have to be under the age of 18 to receive a Tourette's disorder diagnosis. And the ratio is about 4 to 1 males to females that are diagnosed with the disorder. Culturally, there's not a really large significant difference found in rates of diagnoses between cultures or races. The biggest difference that is seen in Tourette's disorder is how it's perceived and treated, and as well as difference to access and care. So, places inner city might have less access to care for Tourette's disorder. So the onset of Tourette's disorder is on average between 4 and 6 years of age. And the peak severity and symptoms is around age 10 to 12. So it is, for usually prepubescent children, have, the general early onset and pretty early peak severity and symptoms. The tics and the symptoms do wax and wane over time, and they may move to different muscle groups. So the tics that a child or adult experiences may change over time and, start out in the hand and move to the leg, something along that course. And as I mentioned before, the tics associated with the premonitory urge are not completely involuntary. They can be resisted, though that would be with great discomfort, and that's not unlike OCD symptoms or OCD rituals. And as I'll discuss in a little bit, that there is quite a bit of overlap with Tourette's disorder and OCD diagnoses. And as the patient ages, as adults, they often experience a decrease in symptoms, though there are adults that feel that their tics get worse as they age. And just a special note that I made here, if the onset is after age 18, they no longer qualify for a Tourette's disorder diagnosis. They would just get a diagnosis of other specified tic disorder with a specifier for the delayed onset. The prognosis for Tourette's disorder, like I said, it does tend to lessen as the patient gets older. And again, as the patient gets older, they sometimes have the addition of the premonitory urges, which is specific to Tourette's disorder. Anxiety, stress, and exhaustion will cause an increase in symptom severity, whereas focus and calm will reduce symptom prevalence in that moment. So a child that is focused on schoolwork will actually display, more often than not, less tics than they do, just in general, in conversation or what have you. Severe tics and severe motor movements can cause disc disease if prominent in the neck muscles. There's also a risk of eye injuries if an individual has really quite pronounced arm movements. And when it gets to the point where they're starting to hurt themselves just because of their tics, they're considered self-injurious behavior, and they often lead the individual to be hospitalized. There is quite a bit of comorbidity with Tourette's disorder. You see in prepubescent children a lot of OCD, so like I mentioned before, these premonitory urges where they feel they need to perform a tic, quote-unquote, just right to kind of alleviate that feeling. It's a very similar idea to some of the OCD rituals, washing our hands 5 times, 10 times to make that feeling kind of go away. You see a lot of comorbid diagnoses of ADHD and Tourette's disorder, the inability to sit still in class, inability to focus, and you see a lot of separation anxiety disorder. For teens and adults, you see quite a different level of comorbidity. You see a lot more major depressive disorder, which may be, due to social isolation, general kind of a secondary diagnosis to Tourette's disorder. You do see higher prevalence of bipolar disorder and substance use disorders. And the substance use disorders may be due to self-medicating. So for Tourette's disorder, there aren't a lot of very specific assessment tools like you would see in a more general psychiatric disorder, because Tourette's disorder is also genetically and neurobiologically based. And it is a pretty obvious disorder. You can see the tics, you can see the movements, you can hear the vocal tics. The assessments for Tourette's disorder are more generally used to determine a child's potential and possible shortcomings. And if an individualized education plan may be necessary, if the deficits that are caused by Tourette's disorder are significant. So again, the assessments are more centered around the child's potential in school and the potential negative impact of Tourette's disorder. And the functional behavior assessments are usually implemented when a child exhibits behaviors that interfere with their ability to learn. Some differential diagnoses, I mentioned quite a few of these. The persistent or chronic motor or vocal tic disorder can either only have motor or vocal. So in this diagnosis, they are mutually exclusive, whereas Tourette's disorder, you need to have both. The provisional tic disorder, as I mentioned, is present for less than 1 year. So someone that has provisional tic disorder, as time goes on, would likely gain a Tourette's diagnosis. OCD-related disorders, it may be more difficult to parse out what is an OCD-related behavior versus what is actually a tic. And then we come to myoclonus, which is also a movement disorder, though they are non-rhythmic movements that are worsened by voluntary movement and occur in the sleep. So Tourette's disorder generally does not occur while the patient is sleeping. And also there is no premonitory urge with this disorder. And the last one here, the abnormal movements that may accompany other medical conditions. And stereotypic movement disorder. This is tics or movements that appear to serve purpose, but they don't. So kind of more stereotypical, waving, they might look like they're waving to someone down the street, but it's more of a tic than anything that they're actually doing. So some treatments, the onset of the use of antipsychotic medications around the 1960s, becoming more prevalent, such as Haldol, haloperidol. And so these antipsychotics are still used today to treat Tourette's disorder, risperidone, clonidine, Geodon. And studies have shown that there is really no difference in the efficacy of risperidone and clonidine. And for a lot of people, Haldol actually has quite a lot of detrimental effects, as do many antipsychotics. They actually can cause more extrapyramidal symptoms. So, ironically enough, people that are on Haldol and Geodon have a lot of these EPS, or extrapyramidal symptoms, which actually cause tics, facial movements, unwanted, movements, so they have to be put on other medications like cogentin. I didn't see anything about cogentin being used for Tourette's disorder, but that would definitely be interesting. Any sort of therapy, psychotherapy, psychoeducation is more utilized to help a patient cope with the symptoms and the social anxieties associated with it. So not a whole lot of therapy treatment and more, just the antipsychotic treatment for Tourette's disorder.